Hello and welcome to the second edition of the Victor Black podcast. In today's podcast, we're going to be discussing the subject of post-cycle therapy. And our special guest who will be joining us today is Dr. Dean St. Mart. Dean is probably, just like Scott Stevenson was last week, better known to you than I am. So I will get Dean to introduce himself briefly, but if you follow my content, you would hear me say from time to time that I am not an organic chemist, but, and I then fumble my way through trying to explain how I see things working often from a mechanistic perspective. Dean, for those that don't know it, is an organic chemist. He, in fact, holds a PhD in organic chemistry, I believe. That's correct, Dean?
Correct, yeah.
Yeah, okay. So maybe you can just give the usual spiel that you introduce yourself. You have a background as a competitive bodybuilder, and you bring your credentials to the table. So maybe you could just, for those people that don't know, you just tell us a little bit about yourself, please.
So I'm Dr. Dean St. Mart. I have a degree in chemistry and pharmaceutical chemistry. So my undergraduate was focused on, the design and development of drugs. And from there, then I pursued a PhD in organic chemistry with synthesizing a new class of fluorescent molecules, which was very interesting. But all throughout that period, I was first a kickboxer, but then I had quite a bad injury to my right ankle. And obviously I was going to the gym as part of kickboxing, and it just sort of seemed like with an interest in fitness and bodybuilding, why not try and compete? Mm-hmm. So obviously that began with natural bodybuilding. And the more I thought about it, the more I started to understand obviously with my background, I started to read some of the things online and started to read some of the sort of underground books. I started to see that there was quite a lot of misinformation there. So obviously I started to apply the knowledge to myself. And then when I met my wife, Morgan, in 2015, after about a year, she kept saying to me, you need to get on social media. You need to start getting this information that you know yourself out to everyone in the world, basically. It's just too invaluable to keep it to yourself. So I slowly started building up on social media, and then obviously I became an educator for Jordan Peter's website. And that's when things sort of really started taking off, because I started to show people certain fallacies that existed within bodybuilding that we sort of accepted as the norm over the last, say, 10 to 15 years. And slowly started to make people more health conscious. So applying functional medicine, which is a branch to medicine where we focus on the root cause of a disease, as opposed to conventional medicine where we just use medication to sort symptoms. And that was sort of where, when I finished my PhD, that I didn't go into any further research or into pharmaceutical industry, primarily because I was sort of a little disheartened that, yes, we do all this research to figure out how to fix diseases, but most of the time, the structures of the compounds that we investigate are more so to manage symptoms as opposed to ever getting to the deep root cause. And then I started to realize that even when we manage health, when it comes to anabolic steroids, we never really looked back at the basic picture of what is the initial disease process that causes, say, liver damage when we take steroids, or what causes cardiovascular disease. And then what, I guess, precautions we can put in place to manage our health based off those root cause principles.
Okay. I was saying to you just before we started the call that I believe I first became aware of your content by watching a piece of, I guess, very important information about post-cycle therapy, the right way to do PTC, as it were, sort of thing. That first drew my attention to you as an individual and your belief systems. And I've been kind of following you along ever since. Maybe, I think it's fair to say that probably most people that are watching this may have either heard you talk about that before, or as a consequence of your efforts, heard me ranting on about exactly the same thing. But maybe just for those that haven't heard that, we can at least briefly touch on the subject of the folly, I suppose is the right word, of trying to restart the HPTA whilst we still have suppressive compounds in play?
Yeah, so I mean, most people are probably aware. So post-cycle therapy, or PCT, is a process which a user of anabolic steroids, or I guess bioidentical testosterone replacement, for TRT, goes through in order to restart the hypothalamic pituitary testicular axis, the HPTA axis. So basically, when we take either exogenous testosterone or we take anabolic steroids, the HPTA axis is basically the system in our body which produces a cascade of hormones for our testicles to then make testosterone. Either through the simplest mechanisms are either we have exogenous testosterone present, which makes our testosterone level go outside our natural physiological range, or the conversion to estrogen goes outside the physiological range also, and that can dampen then the HPTA also. It shuts down the production of testosterone. So when you take these compounds, that HPTA fails to now produce natural testosterone, and it remains suppressed while those compounds are present. Now, most people are probably aware of PCT through either forums or through William Llewellyn's Anabolics book, which has Dr. Michael Scali's PCT protocol, which is called the Power PCT.
Yep.
Now, like I said, my background is as a pharmacologist. So when you look at the design of the Power PCT, the compounds that are being used in it are correct. The mechanism of that PCT is very sound. The issue is somewhere along the lines, someone misskewed the information that was being said, and that there was to be an overlap between the end of your steroid cycle with the start of your PCT. Now, from a basic physiological function perspective, that doesn't make sense, that you basically are putting in compounds to restart the HPTA when there's still exogenous compounds present.
Yes, correct.
And I've seen enough through consultation of overseeing PCTs for people to see this play out negatively. And it's basically because certain compounds will have different half-lives. So based off the pharmacokinetics of those compounds, how they actually get excreted from the body. If you don't fail to obey those pharmacokinetics of how that drug is clearing from your body, when you go to try and restart the HPTA, you know, you're just shooting against the wind, because you still have these suppressive compounds present.
Correct. Yep.
So in an ideal scenario, the hypothalamus makes a hormone called Gonadotropin-Releasing hormone, GnRH, that goes to your pituitary in males and makes two hormones, LH and FSH, luteinizing hormone and follicle stimulating hormone. So those are the two key primary fertility hormones in males. LH then goes to the testicles and acts on Leydig cells, whereby they use cholesterol precursors then in order to make testosterone. And the FSH, follicle stimulating hormone, goes to the Sertoli cell aspect of your testicles and makes sperm. So what we're trying to look at in a PCT is that in most suppressed individuals, FSH and LH are too low of a level to yield any physiological range of testosterone. So it basically became clear to me that there was no point in restarting the HPTA if an exogenous compound was present.
Correct.
And this became even more apparent when we started to move to longer ester compounds like equipoise or nandrolone, decanoate, where we see the half-life of those compounds in around 10 to 14 days. So the total half-life clearance, like the total elimination time you're looking at, is somewhere around 8 to 9 weeks on average for that compound to fully clear from your body.
Jump in there? I have a graphic I'd like to show here, if I can, that I like to show people when I discuss this. This is actually the pharmacokinetics of a drug that was actually developed as part of the development of anabolic steroids as male contraceptives. It's actually a special ester, a long-acting ester that was developed for 19-nortestosterone, or otherwise nandrolone. And in this particular case, you probably can't see it too great on your screen there, Dean, but in the video, I'm sure people will be able to see it full size. You can see, I'll just make a couple of quick markers here. So in other words, on this graphic here, this basically shows 3 weeks at 100 milligrams of nandrolone, followed by 10 weeks at 200 milligrams of nandrolone, and cessation of the drug at this point here. So let's call this week 1 of no drugs. And you can see here, this is the point that Dean's making. It took 20 weeks before the nandrolone reached levels that were not suppressive on the HPTA, which is about 1 nanomole per liter in human beings, so that the HPTA could restart. In other words, the length of the ester that you choose in these compounds has a profound effect on our capacity or our ability to restart the HPTA. And there are examples of extremely long-acting esters, which I don't necessarily say they're valid in our particular tribe, but they certainly have been evaluated in human beings that might take anywhere between 20 weeks and 27 weeks for us to be able to start the HPTA.
Yeah, that's a great example there. And the other thing that's people probably fail to realize is the old school methodology approach to PCT back in the 70s. Obviously, steroids, anabolic steroids, and testosterone derivatives have been in use since the late 60s. Towards more so when we got into sort of the period of the mid 80s to early 90s, most clinicians were sort of in favor of a PCT being basically you just waited.
Mm-hmm.
You just basically came off and you waited for the HPTA to respond, as we've seen in that graph.
Correct.
Now, that can bring with itself health issues, obviously, because you're in that low zero, basically zero hormonal baseline for that time until the HPTA responds. And that can bring metabolic dysfunction, cardiovascular disease risk. So PCT, or obviously the PCT protocols where we use pharmaceutical compounds, is a faster approach to play off this natural cascade of hormone production in the body.
Mm-hmm.
So basically, when it comes to PCT, the number one rule, like we see now, is you have to be patient and allow the compounds to clear from the body.
Mm-hmm.
At that point, I always say, get your blood work done. Now, I've often seen people argue with the video that I put up on YouTube very quickly one day when I just got fed up with everything. I said, I need to get this on video and just put it on YouTube. There will be some inaccuracies to what I've said. Preferably, like I made an example of testosterone and anti taking like 4 to 5 weeks to clear.
Mm-hmm.
In certain individuals, and we've seen in the literature, that can take up to 3 weeks to fully clear. But I'm always going to err on the side of caution that you wait the longest length of time possible for the ester to clear before you intervene at all.
Mm-hmm.
The reason being is, and a lot of people get shocked by this if they send me blood work on before they start PCT, where they've been patient and they've waited 5 weeks post use of testosterone and anti, and their LH is perfect, their FSH is perfect, and their testosterone is back at 19 or 20 nanomolar, and they're asking me, do I need to do PCT? And you know, the simple question to them then is, by being patient, your HPTA noticed there was no exogenous compound present and done what it's supposed to do naturally.
Mm-hmm.
So no, you don't need a PCT, and therefore you're at bigger risk had you started this 2-week post last shot pharmaceutical PCT by introducing HCG and then introducing Clomid.
Mm-hmm.
Because you're jumping the gun before you're actually seeing what's happening in your body.
Yes.
Now, that comes to the other side of the scenario. If you do get to the 5-week period post clearance and your testosterone is suppressed and your LH and FSH are less than 0.3 or they're basically suppressed on your blood work, that is when we need to incorporate a pharmaceutical PCT to speed things up.
Mm-hmm.
Or you just go the old school approach and just stay off and wait and suffer the consequences of feeling miserable.
So the first question I would like to throw out there is, just for clarification, can you confirm there is a difference between potentially restarting the HPTA for the purposes of producing testosterone versus the reestablishment of fertility? These are two different things. Is that correct?
They are, in a sense. Basically, your fertility is going to be controlled by your FSH production. However, you will see in individuals that even if FSH is suppressed endogenously, they are still making transient amounts that still maintains sperm production.
Okay.
So
Many of the male contraceptive trials that were conducted in the 80s and the 90s period basically said, look, most males, most healthy young males will see a reestablishment of production within 12 months, which is a very long time in the grand scheme of things. I read that to be, though, referencing the reestablishment of fertility levels, not necessarily the reestablishment of testosterone production. Am I reading that correctly?
So I guess if you take it from the other side, if someone's FSH is fully suppressed, we obviously know that HCG is synthetic luteinizing hormone. Now, if we incorporate synthetic FSH, which is human menopausal gonadotropin, HMG, sperm production on average takes about 40 days for the germ cells to fully mature. So if we incorporate HMG therapy at a sufficient dose to stimulate the Sertoli cells, even with the HPTA suppressed, it yields significant sperm production after 50 days.
Yes. Yeah.
So I guess when it comes to returning fertility from a natural point of view, re-establishing the HPTA will re-establish FSH production in higher quantities than what is currently at a suppressed level. Mm-hmm. And in doing so, you're increasing the potential for spermatogenesis naturally. Mm-hmm. But yeah, it's. I don't think you can separate the two of them into re-establishing fertility and re-establishing the HPTA, because we can re-establish fertility when someone is suppressed.
Yes.
Through the use of HMG. And I guess that's one thing that a lot of people, and this is probably the first time me discussing it, is that if fertility is the main goal of a PCT, as well as coming off. So first and foremost, the PCT is going to have you making FSH naturally, which will increase your sperm count. But while you're trying to go through the process of the PCT, if you have to go the pharmaceutical route, the incorporation of HMG will ensure that, say, in 50 days' time, you will have a sufficient amount of sperm having been suppressed for quite a while. And again, that's where I guess blood work is important for re-establishing what's happening in physiologically and in the serum.
Yep.
Sperm analysis where it comes into more play then for fertility side of things, so that you have this baseline of where your sperm is now and obviously where your sperm is post-treatment.
Understood. So let me just fire. I have probably more questions than we're ever going to get through in this session, but let me just fire a couple at you. So I have had trouble as a layman understanding the evidence as to why different anabolic steroids. I think it's fair to say that different compounds suppress the HPTA to different degrees. And I think it's fair to say that there is a dose dependency at play as well. So even within a compound, the more you apply, the greater suppression that you see. Can you explain to me in terms that a layman can understand, why is it that when we look at various compounds, let me just throw 3 different ones out there. These are all DHT derivatives, something like Anavar, for example, something like Masteron, and something like Proviron, even though they're all DHT derivatives, have profoundly different effects in terms of their suppression of gonadotropins. Why is that? I would have thought, being from a class of compound, they would have behaved somewhat similarly, and yet they range from, Proviron is not suppressive at all to the point where it has been successfully trialed in fertility trials. It's not current practice because it didn't improve pregnancy rates, and why would you take a medicine that had effectively no effect? But it certainly didn't blunt success either. And another drug like Anavar is mildly suppressive. We see about 30% reduction in LH levels from 40 milligrams of Anavar a day. Unfortunately, many of these studies are done in individuals with disease conditions, so we can't particularly say healthy young men. But anyway. And then you have something like Masteron, which is significantly more suppressive of gonadotropins. What is the mechanism that separates those compounds that makes them more or less suppressive?
That's a good question. I've never actually researched in depth, so
I've heard people say time and time again, it's the degree of androgen action that these hormones have on the human body. But that makes perfect sense to me from the point of view of saying, well, Anavar is not as androgenic as testosterone. And so, when we introduce, 20 milligrams, 40 milligrams, 80 milligrams of Anavar, we see an ascending suppression or a growing suppression of gonadotropins, starting at 20%, 30%, 50-ish% at 80 milligrams. But the thing that confuses me is, well, if that was true, that the higher the androgen component of the compound, the greater the suppression, why does Provarin not suppress gonadotropins? Because I would have thought that was that breaks the rule.
Yeah, again, I guess it's because we don't see, maybe, and I'm only thinking off the top of my cuff, this is something that I will go and get an answer for. I will look into it. Possibly because of we don't see a greater extent for androgen receptor activation from Provarin when we incorporate that compound into the body. We know that the main mechanism of action for Provarin is mainly as an antagonist for SHBG, which in turn then obviously increases free testosterone to allow it to then either get converted to DHT or act at an androgen receptor for its effects. It quite possibly could be, again, oral steroids, again, taking Anavar as the sort of side to it as well. It's not just the androgen receptor that's the affinity for the androgen receptor that's causing, issues for Anavar. Like, we know that oral steroids have less than a 1% affinity for the androgen receptor, that there's something else extracellularly that's happening where these steroids are docking to and turning on response elements in turn as well. I guess it all comes back to the neuronal signal that goes to the hypothalamus for gonadotropin-releasing hormone. That is the key driver for HPTA shutdown. So unless there's something acting at the neuronal level with these different compounds based on shape and conformation, that'll have to be something I'm gonna have to look into, see if there is research there.
Maybe we could revisit that at another point, Blake. So I'll give you a chance.
Yeah, because when we see someone get completely shut down, normally the issue, we tend to break down hypergonadism into two aspects: primary and secondary hypergonadism. So primary hypergonadism, the testicles aren't responding; they're not making testosterone.
Correct.
So there's either a physical issue or an underlying signaling issue back to the hypothalamus.
Is it fair to say that in steroid-induced hypergonadism, it's always basically the testicles that cause the problem? I've seen a number of studies that basically look at multi-year abusers of these compounds, and their pituitary signaling system seems to work, bounce back just fine. It's always morphology changes to the testes that cause long-term issues in the production of testosterone. So it's when we talk about anabolic steroid-induced hypergonadism, it's almost always the testes that are the bottleneck, correct?
It can be, yeah. And I like the way you've said androgen steroid-induced hypergonadism, because we're now starting to see a branch actually to ASIH that actually involves having normal physiological function, but post-steroid use side effects, which is a whole other side to PCT. So obviously, when we say, for example, someone's hormonal level, if they're doing blasting and cruising, which I'm sure people will understand this concept of doing a cycle of steroids and then obviously cruising at a lower dose, or obviously going back to TRT. If you go from that high supraphysiological range back to a physiological range, but is still outside your natural baseline, when you return HPTA function through PCT, it becomes evident that it's not just about returning normal physiological function of the HPTA to produce natural testosterone, because we now start to see either, again, this is improved with research, but there's potentially then that we have resistance to your naturally produced testosterone, or we have understimulation of the androgen receptor itself, because we start to see big issues surrounding metabolic function and also then sexual function, with erectile dysfunction, low libido, even though we've returned to a normal baseline post PCT.
Mm-hmm.
And again, that's a big area that I think we'll need to have a lot of focus on now going into the future, that we understand how to, I guess, fix any problems that arise with the HPTA signaling, but it's now a matter of understanding the actual, I guess, psychophysiology of what happens post steroid use.
I understand. Okay.
And I see it quite a bit with some of the consults that I do, that people, as an artifact of, obviously steroids have neuropharmaceutical effects, they have neuropharmacology to them, that the, you know, increased dopamine transport, the increased serotonin transport, they deplete these neurotransmitters. When we return to a normal physiological baseline, it's not necessarily that those neurotransmitters have returned back to normal levels.
Normal levels, yeah.
Or the receptors are at, so again, we're getting into like neuropharmacology here, but your neurons in your brain have a sensitivity. So they can end up to a point where the neuronal transport is at a, I guess, overstimulated, or they're at the threshold of neuronal stimulation.
Mm-hmm. Does that causes potentially a blunting effect then in the future when you return to physiological levels? Is that what you're implying there?
Exactly.
Okay, cool.
Yes.
Okay,
and then obviously then trying to correct a neuronal or neurotransmitter signaling issue, it's very difficult to do, both with pharmacy as well as, I guess, with psychology. It really becomes a matter of basically time for those neurons to come back to a lower threshold that they actually respond to the neurotransmitter signaling. And that can cause big issues in PCT.
Understand. Sorry, I'm going to jump around a little bit here. Just on the subject of different compounds, I have long had a hypothesis, a recommendation that I make to people just starting out that I've never heard anyone else talk about. I wanted to pass it by you. Feel free to tear it apart if you feel it is not valid. I'm interested in getting to the truth, not, you know, protecting my personal opinion here. I recommend to guys just starting out that you should probably, you know, for a period of time at least, attempt to restart the HPTA. So do a cycle of drugs, start the HPTA, at least until you have made a commitment to this lifestyle, you know, for a couple of years, you know. And consequential to, I don't think that's unusual. Most people would say, like, you should probably start off by coming off, and then eventually you're going to get to the point where it probably makes more sense to follow a model that is phasic in approach, where you have periods of physiological levels and periods of super physiological. I don't like the term blasted cruise, but, you know, whatever. And I've said to beginners, look, you know, I think you would be well served by, you know, carefully choosing the compounds that you choose, because I personally believe that some compounds make it more difficult to start the HPTA than others. An example of that would be the oxidative stress that, you know, we know compounds like nandrolone cause on the testes. You know, we have, you know, I agree they are rodent studies, they're not human studies, but they are interesting. And I've long recommended that people fundamentally stay with, you know, a moderate base of testosterone and DHT derivatives like Anavar, because they are not so suppressive of the HPTA, and stay away from the compounds that seem to do, you know, damage to the testicle ultrastructure. Really, like it seems to be almost like, you know, something that's very, very difficult to come back with. And at least until the point where you've kind of somewhat committed to this lifestyle of an exogenous source of androgens coming in forever, fundamentally. Would you, you know, can you pull that apart for me? Do you think that there's any merit to that? Do you think I'm biased by my opinion on that? What is your opinion about different compounds making it more or less difficult to start the testicular axis based on the oxidative stress damage they cause to the testes?
Yeah, so obviously, like you've pointed out, a lot of people do fail to understand that obviously physiological changes happen to our testicles when we use steroids. And again, the oxidative stress that can happen as a result of these compounds interacting with our body. Again, that oxidative stress yields changes within our arteries, within our heart musculature. So again, the risks are also there towards global health as opposed to just for sexual function. But I do agree with my advice always with first-time users is that you should know your natural baseline before you start any of this.
Absolutely.
So you need to even gather 2 sets of baselines about 8 weeks apart so that you can see, is your LH and FSH staying steady? Then you have this golden number. Obviously, as you get older, this is going to slightly decrease because obviously the HPTA signal drops as a matter of time. But you'll have this number that when you finish your steroid cycle and you go to do PCT, whether it's being patient and waiting for the compound to clear or following through with the pharmaceutical PCT, you know exactly where your goalposts are to return to with
baseline,
with your baseline. So when you do your sort of your first cycle, it does make more sense that what you're trying to do there is figure out how your body responds to a higher level of androgens. So when you get your natural baseline, say for example, it's 15 nanomolar, it probably make more sense for your first cycle to take your level to somewhere around 45 or 50. So you're now going three and a half times your normal physiological level of testosterone, provided you metabolize the compound normally. That allows you then to see what happens to that excess testosterone in your system. Does it get converted to DHT? Does it aromatize? Do you actually see benefits in obviously strength gain, recovery, muscle growth? You know, it allows you to then weigh up, if I push my dose in future, these are the side effects I see at just outside physiological range. When I progress further in and add more compounds, now I understand what happens. Am I going to be at risk of, you know, okay, I'm 5-alpha reducing testosterone at a higher rate, causing more DHT. I see that my strength is rapidly increasing. My CNS is recovering very fast, but I'm losing my hair. I'm getting, you know, acne. I'm getting oily skin. I'm getting excess hair growth. You know, these are the sort of things then that you can weigh up that, okay, if I commit to this at a higher level, these are the sort of things that I have to understand and I'll have to manage. Post first cycle use, most, and I'm not going to make a general rule, but I'd estimate that 90% of people post clearance of the compound by being patient will return to HPTA to normal function with testosterone only, provided they, again, have no underlying genetic issues surrounding HPTA signaling, and also that, again, they weren't silly in pushing too high dose, and obviously controlling aromatization as the compound clears. Because as the compound clears,
of course, that is very well supported by all of the clinical trials that we had in the contraceptive studies, right? Because that's approximately the levels they went to. Agree?
Yeah, exactly. Yeah, in most cases they were given, you know, 250, 300 milligrams in the studies. So I guess if you're patient, and again, you don't allow estradiol to go out of range as the HPTA is starting to recover as the compound's clear, it makes more sense to do that to, again, give you a feel with that first cycle of this is how my body responds to higher levels of physiological testosterone. Then from there, transition into this PCT or clearance period, obviously, and return HPTA function. Still trying to, again, I guess, maintain what progress was made at that higher supraphysiological level. Because obviously then, if you're starting to rely on those compounds to maintain progress, then obviously you're just going down this potential drug addiction route. Then again, you know, you give yourself this sort of clearance period, you understand what happened at that dose, and then you make, you know, sort of by that point, you'll either have a commitment to bodybuilding being being a long-term goal, that if you're a competitive bodybuilder and this is why you're experimenting, that again, doing continuous PCTs, okay, we don't have any studies done that show continuous shutdown and obviously reinitiation of the PCT causing any long-term damage. But to me, it just doesn't make sense for someone, even from a health perspective, that, like I said, when we do a PCT, when we go to that low hormone level, it skews our, first of all, it skews our metabolic rate. It skews thyroid metabolism. It skews how our liver processes carbohydrates and triglycerides. So again, that can feed into developing type 2 diabetes as a result of impaired triglyceride metabolism. When you're going through this period of on-cycle PCT, you're probably doing more damage to your health long-term then if you were to do a cycle, come back to physiological range, TRT, and I mean true physiological range, whatever your baseline said it was.
Back to that.
You know, bring it back to that. Again, you know, there's a little bit of scope there. Say your natural baseline was 11. Well, then, you know, sitting around 18 or 19 isn't going to be as drastic to 11, but you're still coming back to physiological function. And then obviously then you're progressing back once health has been reestablished, and you're happy that baseline health is normal again. Then you go back to your cycle, as to speak, because I hate asking.
So assuming that you were very moderate with your use of these compounds, and whilst you were on cycle, you were getting regular blood work done, and your health markers were, let's call them, you know, within range. You know, I know that's a kind of an arbitrary statement, but let's say there were no adverse events of concern. Do you know? And you went, okay, so I did very well. I kept all of my, you know, my lipids and everything was like, you know, let's call it tolerable levels of stress. Yeah. And you return to a physiological range, which is, you know, reflective of your baseline where you started from. How long would you suggest that someone that was new to this take, you know, before they were to recommence that, you know, rinse and repeat cycle process?
Go back to the cycle. A minimum, in my opinion, 8 to 10 weeks.
Yeah. Okay.
8 to 10 weeks at that physiological range, not 8 to 10 weeks.
No, I agree. I understood.
Cycle, and that's again something that really annoys me about blast and cruising, because someone ends a blast, which in my opinion is a cycle, and then says, "Okay, I'm going on a cruise for 6 weeks."
Yep.
Meanwhile, they've taken like 2 grams of nandrolone decanoate in the last week of their cycle.
Correct.
You know, 6 weeks later, even if they reduce their dose to a physiological dose, they're still at a still
super physiological levels. Agreed. Yeah, completely.
And to me, this whole like, okay, I'm taking 6 weeks off cycle, you may as well just stay on continuously if that's your opinion, that's your belief system.
Okay, cool. Let me jump again to another question. I'm sorry, I just want to try and cover as many topics as we can, because I value your opinion so highly. Can I ask your opinion on, there are a number of compounds that are regularly, routinely used in the fertility industry, if we can call it that we don't see in our community. You know, things like L-Carnitine is, you know, recognized in the fertility industry as a tool that may help restore fertility. It has been compared to Clomid, you know, in trials, and seem to be, you know, as effective as Clomid in that regard. You know, there's you know, a number of different products that you'll see. We don't see these things in our community like as recommendations as it typically were. So, for example, whenever I, you know, make a recommendation to a client about PTC, I tend to include the secondary compounds, the vitamins, the minerals, you know, like in the case of, I'm a fan of injectable L-Carnitine, for example, as part of post-cycle therapy. And that's really inspired by the fact that it seems to do so well for people seeking to restore fertility. You know? Would you say that there's merit to that? Or, you know, why do we not see more people, you know, borrowing these tools from the fertility world, in our tribe?
I'm not too sure, to be honest. That one about L-Carnitine for even fertility is a brand new one to me. I've seen all the studies for L-Carnitine as again a fat mobilization tool, and obviously enhancing fatty acid transport to the mitochondria, but I've never ever seen that for, obviously if it has effects similar to Clomid, that's interesting, because obviously Clomid's effect is as an estrogen receptor beta agonist, so it's, you know, it's docking into the estrogen receptor, the hypothalamus of the pituitary, I mean, and basically in a simple fashion, it amplifies the amount of LH that your pituitary outputs. I've never actually heard of carnitine.
Okay, maybe I'll send you a couple of studies. Again, they're directly taken from the world of, you know, improving fertility. So, you know, boron, alpha lipoic acid, L-Carnitine. There's these staple things that, I mean, even if you go on to, you know, things like, you know, Amazon and look at the supplements. I mean, because, you know, clearly your role as, you know, supplement formulator for supplements needs. There are supplement companies out there making fertility products, you know, selling them, and they have these products. And when you go and look at the products, it's certainly fair that it says there's some clinical evidence to support the argument. But I just never see people using it. I just thought you might have an opinion on it. That's okay.
I mean, the use of antioxidants when it comes to PCT, I am a huge believer in the use of CoQ10, coenzyme
Yes.
Q10.
Well,
Liposomal
that's another one that's directly, CoQ10 is regularly used by the fertility people, as an antioxidant to improve fertility. But we don't talk about it in context of PTC.
No, but I do, like, whenever I have consults with people, most people will then be recommended a list of supplements that the reason why we're using supplements in that regard is actually to protect spermatogenesis, to ensure that when the germ cells are starting to mature, that they form the correct morphology, so the head of the sperm is correct, and they also then develop motility where the tail isn't affected. Because I guess you could get off again on a tangent about fertility, that someone can get their fertility tested and have, 15 million sperm, which is sort of like the clinical established standard reference. Yeah. But just because you have high total sperm count doesn't mean that you actually have viable sperm. Yep. So this is where it sort of becomes down to then is the morphology of the sperm correct? Is the head actually correctly shaped that it can penetrate the egg? Are the tails actually correctly formed and that they have good motility to survive the swim to the egg? It's not just getting your sperm count up, it's also managing that the sperm that you make needs to be made correctly.
The quality of the sperm, yes.
Exactly. And the quality of the sperm needs to be protected, obviously, by lowering that oxidative stress to the Sertoli cells. And that's where alpha-lipoic acid, resveratrol, obviously L-Carnitine has some sort of role.
That's exactly what it's for. It's both as an antioxidant, but in terms of also optimizing energy pathways for the for the sperm themselves, sort of thing. So improve mobility rates and things like that. So
you can imagine how much mitochondria is inside a sperm cell. Obviously,
apparently there's a tremendous amount in your testes. I didn't know that. Like it's very dense.
Yeah. I'm sure it's pretty much probably like our eyes. Our eyes are probably the next source of mitochondria because of the oxidative stress from what we view. But the likes of those, liposomal curcumin, all these heavy antioxidants play a role in infertility to ensure that sperm develops. But when it comes to, I guess, HPTA restoration, all these sort of test boosters, in my opinion, are, the science to a lot of them is very, very questionable. The only one that I've ever been impressed with, and I've yet to see actually work myself, even with overviewing some people's brew work, is Shilajit. We have that study in India where I think it was 37 males where they've seen a huge increase in total testosterone from Shilajit supplementation because of the fulvic acid's apparent effects on the hypothalamus. But I've never seen that work personally. It's always sort of ones where I tell people when they're sort of going through PCT that, this may help, but I wouldn't bank on it being as effective as the ones that we know that actually control pituitary function.
So while we're on the subject of novel agents that we may deploy in that setting, your opinion on Triptorelin?
So Triptorelin, for most people that don't know about it, it's a newly synthesized peptide. When I say new, it's about 20 years old. And it is incorporated in clinical practice by endocrinologists. So it's a peptide structure that mirrors the neuronal, the neuronal docking site for hypothalamic secretion of gonadotropin-releasing hormone. So it basically stimulates those neurons to produce gonadotropin-releasing hormone. So when we see a potential case of both primary and secondary hypogonadism in steroid users, where we're no longer seeing the pituitary responding to hypothalamic stimulation, a educated decision can be made by an endocrinologist to incorporate.
Just interrupt you, Tina. Sorry, I just want to interrupt you there. Whilst you're talking, I've just flashed up on the screen there a pharmacokinetics profile of the administration of Triptorelin. And so you can see the massive spike in luteinizing hormone that occurs on the initial application. So maybe you could talk to that a little bit,
Yeah, that's brilliant. So like I said, when it gets to this point where obviously someone's tried the pharmaceutical PCT of HCG and then trying to initiate pituitary function through the use of clomiphene and potential augmentation with tamoxifen. If someone's on that sort of, I guess, treatment protocol for any more than say 2 to 3 months without any significant improvement to either total testosterone or pituitary function, an endocrinologist can make an educated decision, as well as informing the patient of how this compound works, because there is big risk to this compound that, to me, when this first became available in the underground setting with peptide companies, you know, making this readily available, it was just, I guess, mind-boggling, because if you look at the dose there, it's 100 micrograms.
Correct.
So we're either given 100 micrograms of direct GnRH or 100 micrograms of triptorelin. So you can see it's sort of matched to how gonadotropin-releasing hormone works at the hypothalamic level. With this compound, it's basically a one-shot, I guess, go at restarting the HPTA. So we initialize with a 100 microgram shot of triptorelin, and we wait, and then obviously we draw blood within the first 2 days and see how does the pituitary respond. If it works, brilliant, because it tends to kickstart the HPTA immediately, and the LH and FSH produced go straight to the testicles. If there's no physical damage or anything there, testicles start producing testosterone, and we start re-establishing that HPTA. The hypothalamus will start making its own GnRH. But
would you say that your position so far is you would support that as a last line of action for someone that has failed to start their HPTA through traditional methodologies? Is that fair to say?
Yeah, and I've had quite a few consult clients who have gone the route of going through an endocrinologist for this aspect.
Because my concern is not so much that, obviously, through with the support of a medical practitioner, but people seem to be using it almost by default today. So, like, that's how you do PTC almost, and this concerns me. Are my concerns valid?
No, they are definitely, because I was going to get to, like, the risk here is that if this goes wrong, you will ruin your HPTA and you will be fated to TRT for life. For life,
yeah.
Basically, because, again, how triptorelin works at the neuronal receptor site within your brain, if you overstimulate those neurons, similar to what I was discussing about when you have, chemical imbalance surrounding the neurotransmitters of dopamine and serotonin, if you completely overstimulate those hypothalamic neurons for GnRH secretion to the point where, you've sort of burnt out the receptor, there's no going back. Those receptors can't be fixed by surgery. And again, by time, who knows how long that's going to take to repair itself naturally for those receptors, those neurons, to come back to a lower threshold. So there's big risk here involved, that it's sort of like the person needs to understand that if this goes wrong, then I am fated to TRT. But as it currently stands, I've tried to go the route of an intelligent PCT protocol with obviously trying to establish the HPTA, and nothing has worked. So I'm still, either way, I'm fated to TRT. Correct. If this goes wrong, or, as it stands currently.
So in that scenario, you almost have nothing to lose if you have made a best effort basis using the tools that we have, right? Yeah.
Exactly. Yeah. Like, again, like that's what I mean, that, the risk is sort of like, if someone has potential for the HPTA to return, well then, do you wait and be patient? And again, this is where it got really worrying, because you're seeing online and some of the forums, it's like, you do 100 micrograms of triptorelin every week for a month. Let
me just point out for people that don't know, this drug has also historically been used in the process of chemically castrating men for two purposes: as part of the treatment of prostate cancer, and also, bizarrely enough, in the treatment of sexual offenders, I understand. So if you misuse this drug, you can effectively chemically castrate yourself. So.
And that's exactly it. And then obviously, then the way that's corrected is with TRT. So it's an interesting compound, and it's great that we've been able to devise through obviously pharmaceutical chemistry how to stimulate the hypothalamus, but it needs to be very well respected.
Correct. Not certainly not for beginners. Yeah. Okay.
No.
Okay. So, can you give me your opinion on the potential compounds that might be available to us, either as hypertrophic agents or as anti-catabolic agents that effectively don't impact the HPTA, that we might use whilst we're trying to start the HPTA as a means of suppressing catabolic losses? So obviously your testosterone is not going to be in the best shape in the world. Are there other compounds? I used the example before where I mentioned that Proviron has been used in fertility trials. It wasn't adopted in clinical practice because it effectively made no difference. It neither improved nor degraded the chances of you getting pregnant as a couple if you use Proviron, but it does not appear to have any potential impact on the gonadotropin, like no suppression of gonadotropins, but it plausibly, if used intelligently, might provide some anti-catabolic practice at least. So can you just give me your opinion on the use of these types of compounds, maybe growth hormone, insulin, Proviron, SARMs, these types of things in the context of using them whilst trying to start the HPTA?
So I guess the first one that I'm going to rule out here is SARMs.
Yep.
And that is purely because I'm not sold on a lot of the research that have been done over the last while, because they haven't been as selective as what they were intended to do. Mm-hmm. So obviously people who don't know, SARMs are selective androgen receptor modulators. So when we take an anabolic steroid, it has both myotropic, which is anabolic properties for muscle growth, and androgenic properties. So what scientists tried to do was deduce from the anabolic steroid interaction with the androgen receptor, could we create ligands that selectively seek androgen receptors on myotropic tissue only, so grow muscle tissue only, and avoid the androgenic I guess receptors that are on androgenic tissue. And now that I actually think about it, that whole shutdown between compounds may play into that it's actually interaction with androgenic receptors on androgenic tissues that shuts down the HPTA to different degrees. Because if we're selectively activating androgenic receptors on muscle tissue only through the use of SARMs, which is supposedly then to avoid that HPTA shutdown. So I've never actually thought of that. That just came into my head there as I was thinking through explaining how SARMs work.
I understand your thought,
yeah. So
let me just while you're talking, let me just flash this up. So I have a graphic here for anyone who hasn't seen it. This is the file from evaluation of this particular SARM. When you can see here that the promise is that luteinizing hormone and follicle stimulating hormone with the application of this drug are effectively unaffected. So we see a drop in total testosterone values, no drop in free testosterone, and the premise here is that these compounds don't negatively suppress gonadotropins. Okay? The reality, however, seems to be somewhat different. That's what you're alluding to, Dean. So I think it's probably fair to say that there is some evidence to support the concept, in theory, but in practice, the way that we use these compounds, that many times the dosages that are being used in these clinical trials. And I guess this is my interest. I would suggest that the blood work that I've seen says, once you start to 10x the dosages here, you can take this model and throw it in the toilet. It's meaningless. Yeah. But I'm interested more from the point of view, what would we do if we were to say, take a compound that was actually demonstrable to not be suppressive on gonadotropins at that particular dose, and not use it as an anabolic agent, but to potentially use it as a anti-catabolic agent, as it were, just to try and hold off some tissue loss during that process. So it's not about making progress, it's just about holding these forces at bay. Would that change your opinion if it was the right SARMs that showed this effect? Because it's my understanding that the lowered free testosterone levels that we see with these products are consequential to the reduction in sex hormone binding globulin, not suppression of the HPTA. That's how I understand you see lowered total testosterone levels. So can you speak to that a little bit? Do you still think that that's not something we should be spending our time on? It's a lost cause.
So that's an interesting question, because I've never ever seen a study where we investigate how SARMs act at other steroid nuclear receptors.
Mm-hmm.
So for anyone who's unaware, steroids don't only just interact with androgen receptors. They interact with glucocorticoid receptors, mineralocorticoid receptors. You know, we have different steroid receptor families in our body.
Yep.
And that's where we see this lowering in cortisol production or lower in prostaglandin release, is because these steroid molecules can interact with those glucocorticoid receptors and block them, so that cortisol can't have its effect on your cells. I've never seen a SARM investigate from that point of view, but if it was and we did have data, then that would be fantastic. You know, now that you say that, now I've never even thought of this again. What's to say during PCT that you wouldn't incorporate something like dexamethasone, which is a glucocorticoid steroid that we use for inflammation of the lungs, to again lower the interaction of potentially cortisol and glucocorticoids.
Well, this is why I'll just put it out that I actually, you know, it depends on who's doing it. If you're talking about an absolute beginner or someone who's very experienced, normally the very experienced individual, I'd be asking the question of, so why are you coming off? Like, that would be my first question, right? But let's say you had someone that said, like, I'd been around a while, and that, you know, very often personal choice matters to me. Clients want to do things a certain way. If someone wants to come off, then, you know, I will try my best to support them. And I certainly wouldn't make this recommendation to someone in their first year, but you know, if you had an individual that had said, look, you know, I've tried everything there is to try, you know, all of the metabolic pathways I have modulated, then I wouldn't exclude the use of things like clenbuterol or insulin or growth hormone or any of these compounds, because effectively they don't interfere with the HPTA, and yet they are potentially anti-catabolic agents as a means of trying to stave off losses whilst we restart testosterone production.
Yep.
So, you know, you're following that framework, saying clearly we're not going to be recommending to beginners that you should be breaking out the insulin. But if someone is already using insulin, would you say that if there's a experienced user of insulin, and clearly you end up with this it's almost a theoretical conversation, because who is that guy, right? Like, that guy's not coming off, right?
Yeah.
But if that did exist, would you say that there's merit to that, or would you say you should just leave the whole, you know, endocrine system alone during that period of time and leave it to its own devices?
No, I do. Again, this isn't a conversation I've ever had before. The use of insulin, in my opinion, would be quite warranted in a PCT setting for someone who's coming off fully. Number one, because of it, like I said, there is metabolic dysfunction that will happen at that low hormone level when you're trying to restart. Obviously, if you've been at, like I said, this high level of testosterone for a while, your ability for glucose oxidation is quite high. And again, that's where we can see, you know, favorable partition of nutrients when we're at this higher hormone level compared to physiological. But we can also then run into an issue with pancreatic stress, where we're not actually processing carbohydrates correctly and we're creating more triglycerides that again will further impact pancreatic and liver cell health. So the use of a small amount of insulin would definitely take some of that stress away from our pancreas and ensure that we are actually shuttling or transporting the glucose that we are ingesting into muscle tissue, for example, for glycogen replenishment and recovery, because recovery is going to take a big impact as well from being in that low hormone environment. I guess as well, the use of growth hormone, if sleep starts to suffer, obviously because of the imbalance between testosterone and estrogen in our body and how they affect our neurotransmitters again, the use of growth hormone before bedtime would just favorably augment, again, natural recovery to ensure that we are getting some level of exposure to global growth hormone levels in our body. If our deep sleep, say, for example, was starting to begin to suffer at the start of a PCT. But so definitely, it's...
So maybe.
Yeah, maybe. Like, I mean, I'm all well for, you know, if this is an athlete who wants to, I guess, come off for personal reasons, but also wants to maintain some level of, I guess, physique enhancement playing off some of these natural pathways that don't negatively affect the HPTA, well then yes, insulin and growth hormone aren't going to have a direct impact back to the HPA, as would, you know, the use of clenbuterol, or God forbid, if someone wanted to use heavier fat burners like T3 to, again, just augment metabolic rate during that low hormone period.
I understand. Okay. Cool. I am bouncing you around. I apologize. I just a few more questions, if you don't mind.
Yeah, no problem.
We've just crossed an hour, so I won't keep you too much longer. I just want to flash 2 or 3 quicker ones past you. So, can you speak to the idea of a post-cycle therapy for enhanced women?
I'm not a huge expert when it comes to female, I guess, female hormonal health. That's sort of where I'm very good friends with Victoria Falker, and I tend to, you know, have regular conversations with her surrounding, you know, female health. So I'm not hugely confident. Again.
Okay, maybe you could reach out to her and ask her to come and explain it to us. That would be awesome.
I'm sure she'll be delighted, because anytime I get any females that come to me with any sort of development of, I guess, androgenic side effects or potential, you know, female physiological issues as a result of hormone use, I'd rather a female to consult with, because of obviously they're able to understand from a psychological level as well the impacts that can happen. I guess the biggest flaw that I see, and obviously I'm just an outsider looking in, is they tend to just, coaches for example, just tend to tell females who use anabolics, Vitex is sort of, you know, the Vitex cagnus is sort of the natural herb that we don't really understand exactly how it modulates estrogen and progesterone, but it does. That you just tell their female competitors, like, take massive doses of Vitex, and, you know, in 6 or 8 weeks time we should have your cycle back, which to me, how androgens interact with females is on a completely different level to how it interacts with males, because we don't have that same HPTA feedback.
Can I tell you my experience, and then you can just maybe give me your opinion on my experience?
Yeah.
So with my experience, I think it's fair to say that the anabolic stimulus required for women to see quite outstanding results is tiny compared to men. Very, very, very small compared to men. And let's assume you had someone who stuck to the usual suspects. Let's just pull Anavar out of the drawer for a minute, right?
Yeah.
So I mentioned before the difference even in men, where you compare the impact of Anavar on gonadotropin suppression compared to something like nandrolone. It's like night and day. It's like completely opposite end of the spectrum. Even in 40, 80 milligrams of Anavar in a male, which is a ridiculous dose for a woman. It's just eye-watering for a woman, doesn't fully suppress gonadotropins in men. And so in my experience with women, if you are applying a very small amount of Anavar, let's say 5 milligrams a day, you don't actually shut down gonadotropin in the model at all. You suppress it. And so by removing it, what you find is it comes back fundamentally by itself, and you don't need a PTC. This is my opinion. I would agree that there are individual women out there that are using androgen levels that would rival some men. And in those individuals, the discussion changes completely. But that's not my audience. They're not my client base. My client base who are using moderate levels of things like Anavar, that because of the nature of Anavar and because of the nature it is not as suppressive as other compounds, I find if you simply remove that very small amount, that the system resets itself in very short order, because clearly it's not an esterized drug. It takes a very small amount of time before you can go and get blood work and go, man, like everything's back to normal. So
I mean, I completely agree with that, and that's what I have seen myself, obviously. And this is where, again, it becomes a sort of dose-dependent fashion.
And compound selection,
But the other side of things, I'm going to touch on this sort of briefly, is sort of then the health side effects that manifest due to stronger androgens like testosterone derivatives and injectables that... So in males, higher levels of testosterone cause calcium release from our bones. We know that. And obviously that calcium can deposit in our arteries and cause plaque. But the same can be done for females. so there, you know, there's this sort of balancing act that testosterone leaches calcium, estrogen puts it back in. That's sort of like the seesaw to the two of them. With females, when you push their androgen levels higher than their normal physiological level, that testosterone then has the ability to leach calcium from bones and change facial structure. That's how we start to see, you know, square jaw starting to develop in females, is because we're getting that calcium removal from structural structural surfaces, and obviously it gets redeposited, or it gets deposited into arteries, or it gets excreted.
So, sorry, just while you said that, that's interesting you said that, because if you consider, like, for example, the drug Trenbolone, when Trenbolone was in human clinical use, it was prescribed for indications like osteoporosis.
Yeah.
So that's somewhat conflictory to what you just said, is it not?
Well, I guess from a structural point of view, Trenbolone itself is going to have, again, how testosterone causes calcium removal, I'm not exactly entirely sure of the mechanism.
Okay.
But I know between the two of them that this is why it's important that when females enter into, say, menopause, that estradiol levels as well as progesterone should be carefully
managed. Yeah, correct.
And that's sort of where, I guess, what I was trying to get there is with a female PCT, that when that sort of structural change happens because of, say, for example, testosterone use, when they're left with, I guess, structural changes to their bones, I'm not too sure how you reverse that.
I don't think you can. It's permanent, isn't it?
Yeah, so you know, like when it comes to PCT with females, the restoration of their menstrual cycle of menses, of LH and FSH production, and as well as the correct cascade events of estrogen increasing and progesterone decreasing. Yes, I probably would say that when you remove certain compounds in females, that once the drugs have cleared and there's no underlying, you know, metabolic issues or dysfunction towards thyroid health, or I guess I don't see an issue with the pituitary then starting to signal FSH and LH in women. In that
no, because we don't see that problem in men. As I said, like before, it's my understanding that most of the problems that result from anabolic-induced issues are with the testes. And you take that out of the picture, and it's going, okay, well, you know, men without testicles don't have a problem with steroid-induced hypergonadism. It's the testes that is the bottleneck or the weak link in the discussion most of the time. Yeah.
Yeah, Victoria would be great in that she'd be able to describe on a physiological level exactly what happens to a female in terms of their physiology changing.
Fabulous. I will endeavour to get her to come on and explain things to us.
I will listen avidly when she describes
that would be cool. Okay, one last question. I am interested in overall your opinion. We did just briefly talk about SARMs. I would like, you know, as a closing question, to get your opinion. I personally am very interested in tissue selectivity. I think anybody that uses these compounds has to be intrigued by the idea of a compound that, you know, applies its effect where we want it to apply and leaves the rest of us alone, you know, in grossly simplistic terms. So I'm certainly not, you know, anti-tissue selective drugs. In fact, the approach I have always taken is that, you know, when testosterone was synthesized in 1935, almost immediately they started, you know, modifying the testosterone molecule to make it tissue selective. And so I see so many of the drugs that we use effectively as steroidal SARMs. And so non-steroidal SARMs are just a logical, rational extension of that discussion. But I am disappointed by the drugs that we have to date in terms of their, their efficiency and their safety profile. These are things that concern me. What is your opinion about the application of today's generation? What's available on the market today of non-steroidal SARMs as performance-enhancing drugs?
I guess we always trying to go back to when these were all first developed, like mid 2000s, the non-steroidal based that have that like piperine backbone to them. And obviously the one that made it the furthest that never actually came to market was S4 or Androgen. We got to a certain point, and then I'm not even sure, is Osterine's phase 2 clinical trial still ongoing at the moment?
Yeah, what they did was they withdrew. There is a huge unmet need for a non-steroidal SARMs for the treatment of sarcopenia. The problem was that the FDA basically requested the developers to do pretty extensive cardiovascular safety profiling, because effectively you're giving a drug to otherwise healthy people. And what they decided was it would be easier for them to pursue the muscle wasting in cancer patients, because the FDA are a little bit more lax. So when you have a disease state like cancer, if the drug's not perfect, safety profile, they might let that push through because of the many benefits that it would bring to the table, as opposed to a otherwise healthy. So it's my understanding that they withdrew from the sarcopenia trials and currently have redirected their efforts towards muscle wasting in the context of cancer treatment.
Yeah, because I think I see, again, I don't really follow SARMs too closely, because when I was doing my PhD around 2008, 2009, SARMs were a big thing. And I remember actually giving a presentation in the chemistry department on these compounds, of how they were synthesized, how we done the SARs, which is the structure activity relationship studies, to develop this sort of backbone molecule. And it just seemed that as time went on, a lot of companies abandoned their, I guess, computational efforts to further optimize these compounds, because there is no clinical need, as you said, currently, or there is no, I guess this was another reason why I didn't go into the pharma industry, is that there needs to be an incentive money-wise for a compound to be chosen as a lead compound, because it takes about 15 to 20 years for a compound from proof of concept to lead model development to actually then developing lead compounds to lead into clinical trials, phase 1 trials. At that point, you've wasted I'm not going to say wasted, but you've devoted at least 10 years of your time.
Your life's work.
If you're like me and you finish with your PhD at 24, 25, if you enter into something like that at lead compound development, you're in your mid-30s, you've spent 10 years trying to get this to market, and then you get to clinical trials and either they fail, or the company then realizes the return of investment, to generate a product from, concept to end is about $1 billion on average. It's somewhere around that mark. The company needs to be seeing that, okay, when we develop this compound, we'll have exclusivity to the market with our patent for about 15 to 20 years. But that patent sort of gets filed when you start to enter into clinical trials. So by the time you actually get to market with the compound, you might only have 8 or 9 years time to gain back that money through pharmaceutical sales. And I guess unless it's sort of a global problem, a lot of the companies abandoned it. They thought, we have these anabolic steroids that we've devoted time to back in the 60s, 70s, that we know are approved, have good sound clinical data. More specifically, the use of oxandrolone in burn patients or HIV patients in the past. That what is the return of investment on these compounds? And a lot of them by 2013, 2014 start to abandon them.
So from a mechanistic point of view, this is the great question I have about SARMs. You always see these trials at what you would consider to be very small dosages, 1 milligram, 3 milligrams, 5 milligrams. And yet on the flip side of that, you always see that, the results of the trials come back basically with them saying, look, what we really need is more tissue selectivity and more powerful anabolic outcome. And that begs the obvious question, what the fuck don't they just use more like we do in our tribe? They test 3 milligrams and some guys using 30. My argument has always been the reason they don't do that is because as you raise the dose, you tend to lose the tissue selectivity of the drug. And so it goes from being a fabulous profile, like, wow, that is impressive, to, yeah, that's just a competitor to Anavar now. It has many of the same side effects as Anavar. And as you drive the dose up, it becomes more and more androgenic in nature and it loses selectivity. I mean, I just look at it and logically say, well, if they keep failing these functional tests, like, for example, one of the great problems has been, so we see increases in lean body mass and improvements in body composition, but not improvements in functional outcome. Why don't they just increase the dose? And my personal belief, my layman's belief is because when you raise the dose, you lose the tissue selectivity of the drug. Is that valid?
Possibly, but also, I guess what's important to consider here is that from a functionality perspective, from someone who is in the older generation, this is where sort of Anavar shines through, because most people fail to realize that when they take testosterone, and that I spoke about a little bit earlier on, the sort of performance gain that you get from testosterone is from DHT actually, and how DHT makes our nervous system more resilient and confers strength to our body.
Mm-hmm.
I guess the issue there is that you're not, I've never seen again studies on SARMs that actually look at how they affect the nervous system.
Mm-hmm. Mm-hmm.
And possibly when you increase the dose like that, do you start to see effects in the nervous system that would give a performance benefit without having some of the, I guess, cytotoxicity of Anavar? It'd be a good study to do,
but we yet to see it. Yeah, we yet to see it, right? That's the great unknown. We don't know.
Yeah, that's what I mean. Like, so obviously we're sort of left that, you know, people putting up anecdotal reports on forums of, you know, I took, you know, LGD at, you know, 100 milligrams, and I seen, you know, this comparable effect, in my opinion, compared to, you know, 50 milligrams of Anadrol. But I don't know. I'm always just wary of sitting back and thinking, you know, with the current anabolic steroids, we have sound research over 40 or 50 years that, you know, we've been intelligently been able to understand, okay, this is how they work.
The good, the bad, and the ugly, yeah?
Yeah, and this is how, you know, this is how they affect our health on a mechanistic level. And these are sort of, you know, the quote unquote safe dosage ranges that we've been able to extrapolate as a bodybuilding community versus the medical literature. You know, like, you only have to go back to when, like, the Anabol was first synthesized. Like, the dosage prescribed by the initial, you know, reports was like 5 milligrams. And then obviously competitive athletes, this is sort of where the whole scandal of doping and bodybuilding sort of picked up, was because athletes then thought, okay, if I take 15 milligrams, this is going to work better. And then other athletes thought, well, if you're taking 15 milligrams, then I'm going to take 30 milligrams and get even more of an effect than you.
And of course, you know, even dating back to the 1970s, we have discussion papers that, you know, suggest athletes were taking up to 300 milligrams of Dianabol in a day in the 1970s. Not everybody, that wasn't typical, but there were certainly individuals that were showing adverse events that presented, you know, to medical professionals, and there were problems, and that wasn't coming from 15 milligrams of D-bol. So yeah, that has been with us for many years, and I'm sure it's not going away. It's certainly not a new problem, and it's not going away anytime soon. Anyway, listen, we're up to an hour and 30. I guess what I would like to do is just profoundly thank you for coming on. Maybe I can get you back at your convenience at some point in the future, because I have 1,000 subjects I would love to hear your opinion on. Can you just tell the people that are listening a little bit more about where they can get in contact with you? I know you said a number of times that you offer consultations. Maybe you can just pitch the business a little bit for us.
So if anyone wants to follow me, obviously my Instagram is DNSTM. I'm not on Facebook as much, to be honest. I just got bored of a lot of the discussion on Facebook and the same silly sort of questions over and over again. So I don't tend to be on Facebook as much. If you add me on Facebook, you probably won't. I think the last time I posted on my personal Facebook was like probably March or something, and I don't even tend to put a lot of my ideas on even I have a Facebook page that's linked to my Instagram. So even if you follow me there, if you ask me questions about stories I put up because it's linked to my Instagram, half the time I don't know what you're talking about, because it doesn't tell me what I'll get a DM on from Facebook about something I posted on Instagram. It's like, what's that, mate? And I'm like, oh, what is it? Because it's not telling me.
So Instagram. What's your username on Instagram?
So my Instagram is DeanSTM, DeanSTM.
Okay.
So I tend to put, all my highlights are up there. Any sort of I guess ideas that come into my head where I first, there's a lot of highlights on my main profile surrounding PCT, general discussions surrounding, AAS, I have a YouTube, which is the same, DNSTM, where people can go and watch the PCT video.
Okay, I'll put a link to that with this video so people can watch that. Yeah.
There's two paragraphs underneath that video because I get a lot of questions about the video. I've wrote out a basic summary with the literature references surrounding the protocol and, you know, why it may work, that you can follow. You can apply your own example to and follow through it. And then I guess the last thing is supplement needs. Obviously, we mentioned them. I'm the product formulator for that company. So I put together, you know, a range of supplements specifically geared for bodybuilders. I got very, I guess, frustrated with when you're buying health supplements before. It was like I had to buy from Amazon, I had to buy from iHerb, I had to buy from all these other different sort of websites to get different products that I wanted. And so I approached Lee, who owns the company, and said to him, I have all these ideas. I'd love to come on board as the product formulator. So we come up, you know, with a sleep stack product, the CV, which is the heart stack. You know, we had a kidney and blood pressure stack, liver stack. You know, I put all these products together that when bodybuilders get their blood work done and they see potential issues with their blood work, they know they can go to one website and order one bottle of something, and it's at clinical dosages of ingredients that actually have proven research to work.
Yep. Awesome. Very good.
So the website for that is supplementneeds.co.uk if anyone wants to go to.
Do they, out of interest, do they ship internationally?
They do, yeah. Yeah, I know he offers flat rate shipping throughout the world.
Okay.
We are looking at distributors now around the world to sort of start spreading it out globally, because I know the shipping can get a little expensive for further destinations.
Awesome. Thank you. I appreciate your time. I think you're a tremendously valuable asset for our community. And as I said, I will be very selfish and press you again in a couple of months to try and get you back on again, and we can talk about, you know, some other subjects that need to be unraveled, I think, for our community. So thank you very much, Dean. I appreciate it, and I look forward to seeing you soon, buddy.
Thanks a million, Victor. Speak to you soon.